Mr. Monty, anything?
No, thank you, ma'am.
Okay, we will move on. Glasses on so we can see. To item 5, page 25 of the agenda, to dental services in Medi-Cal.
Thank you so much. Mary Cantwell again for Department of Healthcare Services. First, with respect to the two proposals that we have, the first is proposed trailer bill language that would change the existing statutory requirement on our CHDP programs and providers, where they are required to refer kids to dentists at the age of 3 to now have them be required to refer to the dentist at the age of 1, which is consistent with all national guidelines on this issue. The second is that we are proposing to include allied dental professionals, such as registered dental hygienists who are employed by public health programs, as allowable billing providers in the Medi-Cal program, and we're currently working on a state plan amendment to enact that proposal. In terms of the other issues, there were several questions that we were asked to address, so I will attempt to do that, and then certainly can take more questions after that. First, with respect to how we are working on improving utilization of services for children and meet the CMS targets that we have in terms of increasing utilization by 10 percentage points. There are several things that we've been doing. First, one of the items discussed in the agenda is the mailing campaign that was a part of the previous budget. We did send out a mailing to 555,000 parents or caretakers of children ages 0 to 3 who hadn't received an annual dental visit in the last year. Since those mailings, we've seen an increase in our daily call volume at our call center of about 250 calls a day, which is about a 10% increase. And we're going to be tracking that data in terms of the impact to utilization pre the letter going out, and then seeing how many of those kids actually are able to come in and receive a service. Additionally, we are following up that letter with a call campaign that's currently underway with direct calls to those households to make sure that they receive the mailing and see if they have questions or need help in finding a dental visit. A couple of the other things that we're doing that I would highlight, in partnership with Los Angeles stakeholders and the Medi-Cal managed care plans in the county, there is a medical dental collaboration project where the objectives are to really increase the use of dental services for children ages 0 to 6. And this is a targeted campaign on primary care physicians to encourage them to, if they have patients who are not utilizing dental services, to provide a referral to dentists. In addition, we have, as noted in the agenda, been working with our Delta Dental contractor to have mobile vans be available for services in various areas. Right now, we are targeting three counties that have very low provider participation: Alpine, Amador, and Calaveras. And we're anticipating that we'll have those up and running in the next month or so, and then we'll continue to look at how we can expand that. These vans would be visiting sites where it'd be most convenient for children, such as schools, and we're really hoping that we'll see an increase in utilization from being able to provide services in locations that are more accessible to these children. Also, we did recently release our waiver proposal and had our webinar yesterday to talk about what we're looking to do over the next 5 years in the Medi-Cal program more broadly. We have included proposals related to dental, really targeted at increasing provider participation. And we're really interested in having further conversations about how we look at integrating dental into our whole person care concepts that we're looking at, where we're looking at integrating care across the spectrum, and think that dental would be a good addition to those ideas. And so look forward to working with the legislature and with stakeholders on how we do that in the context that we have today. With respect to the rate issue, obviously you all know that we don't have a rate proposal right now, and that is not something specifically that CMS has raised with us as something they are asking us to do as a part of our work with them on increasing utilization. One of the, certainly rates is one aspect of potentially increasing utilization. There are many factors that we've seen. One of the things that we are concerned about and are looking at understanding better why it's happening, our dental providers report that there are often upwards of 50% no-shows to appointments. And so that is one of the challenges that we're facing. How do we make sure that that beneficiaries are able to get to the appointments that they have, so that access isn't being restricted to others who maybe could have taken that appointment? And so we're going to be working on how to address that. One of the interesting things to look at as we've started to do additional data analysis, we've looked at over the last 10 years what has dental utilization for children been. And interestingly, absent a rate increase, we've actually seen over a 15 percentage point increase in dental utilization. And so how and why that was happening, but we have seen that. And so we'll continue to figure out what are the ways we can, what are the things we can do to help increase utilization of services, and certainly are happy to provide any assistance on any ideas that the legislature would be putting forward. In terms of ensuring timely access to services in Dent-A-Cal, one of the things that we've implemented is a warm transfer process. So if a beneficiary or a beneficiary's parent is calling our call center, what we've implemented is the ability for that call center to locate a dental provider that is accessible to that individual and actually get on the phone with them to that dental provider and do a warm transfer to help ensure that an appointment is being accessed to them. And we actually do keep a referral list that's updated weekly to ensure that there are appointments available in certain providers and that we know where to refer individuals to. We also are making sure that beneficiaries are aware of the accessibility of services at a number of our federally qualified health centers who also provide dental services. That's often, a very convenient way. Those clinics are often located in communities where there might not be other providers. And finally, we are tracking our call center performance by looking at how quickly our appointments being made available and ensuring that the appointments do meet timely access standards that we've adopted from the managed care system. With respect to the audit findings, obviously a couple days ago we had a whole hearing on this issue. I think as you heard Director Kent say, this is a top priority for her, it's a top priority for all of us. Ms. Malo is the Deputy Director over this area, and obviously it is a program area under me as well, and this is something that all of us are focusing a lot of our time on, and how do we address a lot of the issues that were raised in the audit. Specifically, we are looking at the recommendations for how do we increase provider participation and utilization. As we discussed in the hearing on Tuesday, we are looking to release some suggestions on some of the ratios and metrics that the audit asked us to develop, and we want to have stakeholder input on those so that we can then implement them this spring. And let's see. Then there was a question about if we've explored the use of Medicaid funding for the California Dental Disease Prevention Program. We haven't specifically looked at that. What we do know is that likely portions of that program could be funded with federal Medicaid funds because they do serve Medicaid populations, but it also serves non-Medicaid populations, so the whole thing would not be available for federal funding. And then finally, in terms of the status of the dental managed care report that was due to the legislature a few days ago, it's currently going through the final review process and should be released in the near future. So I'll stop there.
I need a little something more definitive than near future.
I don't have something there.
This spring, next spring.
Oh, very, 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 like in the next, month?
Within the month.
Thank you.
Happy to take questions.
Senator Monty.
I'd like to maybe hear LAO and finance, and then I do have some questions.
Sure.
Thanks.
LAO? They have nothing. Finance?
Yes. Nothing to begin there. Well, thank you for your presentations today, and specifically this focus. And we did engage some on the rate review issues at the hearing the other day, and Director Kent indicated that there is a commitment to the annual rate review. Is that something you can testify to today as well?
Yes, absolutely. So we are committed to having that done and completed in by July.
And have you formed any opinions as to whether current low rates are a deterrent to providers being willing to take Medi-Cal reimbursement, Dent-A-Cal reimbursement?
I mean, I think, as we talked about in the hearing, certainly higher rates might help drive provider participation. I don't think that we deny that. Whether, in fact, what level and how much that might impact is the question that I don't think any of us know the answer to. And that is where our concern has always lied, is how do we make sure that what we're doing is actually about increasing utilization and not just increasing spending. And so that is what we're going to continue to look at.
And do you have any data, or do you intend to develop any data that looks at the savings when we do invest in prevention, dental prevention, particularly for children?
So that's definitely one of the things we're interested in looking at, sort of broadly including dental prevention as part of our waiver. As I mentioned, we're really interested in how do we start looking at the delivery system as a whole and really look at it being something that is easier for a beneficiary to access. And so we're really excited about the proposals we have in the waiver to really focus on the beneficiary as the center of what we're talking about and not the separate siloed systems that we have today. And so one of the things we want to demonstrate is that increased preventive services of any kind, including dental services, can actually help drive longer term cost savings. And so that is one of the things we'll be evaluating as part of our Medi-Cal 2020 waiver.
Good. So I'm glad to hear that's part of it. At page 27 of the agenda, you do reference the Medicaid waiver renewal and plans to include proposals regarding providing provider incentives to increase preventive dental services in Denti-Cal. Can you give us some idea of what some of those incentives might be?
Sure. So the two that we have right now included in the proposal, and as I've indicated when we've talked about this and on the webinar yesterday, we're interested in getting a lot of feedback on these proposals and other ways to improve it. But the two specific proposals, as part of our overall waiver, we're looking at obtaining federal state shared savings, and we're looking to then reinvest that into the program. And one of the ways that we would be suggesting to spend that funding is to provide targeted incentives to providers who are either newly joining the program, and dental specifically is one of the ones we've looked at, as well as existing providers who are willing to expand the number of Medi-Cal beneficiaries that they see. And in particular, we want to look at, is there a way of doing that differently across different geographic areas, given that we know that there are certain areas where finding providers is more difficult than others.
Thank you, but what form would the incentives take? Would it be increased?
It would be a direct incentive payment of dollars.
Incentive payment.
Yes, sorry. I thought that was clear. I apologize.
It's maybe implied, but I just I want it to be
payment.
clear.
It would be taking that federal state shared savings that we're seeking as a part of the waiver and using that to actually pay that funding to providers.
Thank you, because an incentive could be a plaque on the wall.
You're right.
saying, Thank you.
Or a giant toothbrush.
The kinds of incentives we get for doing our jobs.
Good. Thank you very much. Thank you, Madam Chair.
Thank you, Senator Monning. First, let me just say rhetorically that this is an area that I find frustrating because I am not sure what part of reimbursement rate and the correlation between utilization and access is not clear. It's crystal clear to me. I was around working for a legal services organization in the early 90s when the state lost the Clark lawsuit. And I think we thought that we had made major steps toward improving access under Denti-Cal. But here we are in 2015, really asking ourselves many of the same questions over and over again. So given the Clark history, and I'm sorry that I saw portions of the big joint hearing this week, but I wasn't able to attend in its entirety. What is the department doing to determine equal access in both the Medi-Cal program as well as the private sector to access to dental services, which was kind of the core root of Clark?
Sure. So what we are doing, and these were some of the recommendations of the audit, is how do we develop metrics to actually do that measurement? And that's what I mentioned before, that we're working on developing some proposals around that we can then share with stakeholders and obviously the legislature to ensure that the measures we're thinking about are what people think will get us to that level of measurement. And so we'll be sharing those out in probably the next couple of weeks and then look to actually start using them to measure in the spring.
And so for finance, is the administration basically waiting for these kinds of metrics and analysis to determine whether or not you feel increasing the reimbursement rate is worthy? What are you waiting for?
Yanley, Department of Finance. There are a few things, but looking at the data, some of the studies that the department will be working on will be a factor. So those are a few of the key things that we'll be taking into account.
And so you'll be taking them into account for May revise, budget, fiscal year,
to the extent that
27, 28, when?
To the extent that when those reports are ready, we'll have that discussion.
So furthermore, according to the audit, more than half of the children enrolled in Dental Cal in 2013 did not receive care. What's your response to that, and what's the criteria you use to determine whether the department is, whether network adequacy really is appropriate?
Sure. So obviously that the data is the data. We measure it a little bit differently than the audit did, and they noted this in their audit. We use the HEDIS measure, which is for children who've been enrolled for 11 of the last 12 months, so that you're not counting someone who just got enrolled in the last month. So we have a little bit slightly different numbers than them, but definitely acknowledge that.
Do your numbers show that significantly more children receive?
No, that's what I'm saying. Slightly higher. I think we're for 2014. I think we're at about 52%, if I recall correctly. We're above the 50%, which is not a bar to use, but it's sort of slightly on the other side of 50% than their data. Now I forget the question.
So what are you doing to address what are you doing to address the now 48% of kids who did not have access?
So doing
or didn't utilize services?
Yeah, so doing some of the things that I mentioned earlier in terms of we did the targeted outreach campaign for the kids 0 to 3 who hadn't had a dental visit, making sure that we have the warm transfer process so that if someone is calling and needing an appointment, we're actually making sure directly that they are getting that appointment. And doing some of the things that, we have this program that we're doing with the plans in LA County to get the doctors involved in, if they know that the patient they're seeing has not seen a dentist, to make that referral, so that there's a multi-prong approach about making sure that people are educated about the services available. So sometimes, certainly we think people don't know, particularly because we are in a heavily managed care environment, but the dental services are not a part of that plan, and so they might not sort of realize that these services are available separately from that. So we are trying all of these different things to increase outreach and education and simplify the process for providers.
And I just have to also say, in your earlier comment with regard to the use of mobile units, as we look at developing a network and a system that is of high quality and sustainable and maintaining network adequacy in a respectable way, I just have to say, the whole notion of mobile units for historically underserved communities is not a permanent long-term answer. It's simply not an acceptable solution from my perspective. I appreciate it may be short-term in 3 counties that have a severe issue, but I don't think it's prudent for the state to direct resources toward mobile units as opposed to doing what we know we need to do in terms of expanding network adequacy and just expanding access across the state. I just am compelled to say that. Okay. I heard horror stories from the PDI Surgery Center. I was reminded retired Senator Chesborough would always bring this issue to our attention in Sub 1 on the Assembly side, and it has to deal with anesthesia coverage, particularly with regard to children, and the tragic reality that many children are papoosed or tied down when no anesthesia coverage is available. And all as a direct result of low reimbursement rates. What response do you have to that?
Certainly, I think there's a couple of things. There's one, the issue of, certainly we know that there have been providers who have stopped providing those services, and that is something that we are working on, figuring out how we can deal with that. I do want to note, obviously, we did one of the groups that was exempted from the AB 97 reductions were the pediatric surgery centers for the reasons of access concerns, and that is within our authority to do that, and that is what we did as a department. The other issue that certainly
so they didn't receive an additional reduction, but they're still saying in terms of what their Medi-Cal reimbursement rate for anesthesia is less than half what real costs are. $44 per hour is what Medi-Cal pays for anesthesia. $11 per unit of 15 minutes. The actual cost is $300 per hour.
Yes, absolutely. And I think one of the things we've talked about is for the authority that the department has is to undo the AB 97 reductions when there are issues.
Augment.
Right. And so in addition to that issue, I know that there's been an issue about inconsistent application of utilization controls on the use of dental anesthesia. So that is something where we have been working collaboratively with stakeholders, both on the dental side and on the medical side, to work on developing consistent guidelines that would govern that across the state and across health plans. And there's the balance here between making sure that for those kids who need anesthesia, that they are appropriately getting authorized to have that be utilized, and balancing that against for kids who maybe don't need it and would, there are risks in using anesthesia just on anyone. And so we have had some concerns about overutilization for children who were not necessarily needing anesthesia, who didn't have special circumstances that would require that. And so we have been working to have that consistent policy, and it's been shared with stakeholders and plans, and we are working to finalize that so that there's consensus around what those guidelines should look like.
So when you said that you aren't authorized to augment, that you were able to prevent the surgery centers from experiencing the additional hit, are those rates set in the budget, in state law? Where are they set?
So
who can authorize the increase?
A budget action or statutory change.
Okay, great. Okay, Senator Monty, anything else? Finance and LAO, nothing. Public comment, thank you. 2 minutes each, please. First witness.
Hello, Madam Chair and members. My name is Dr. Irving Leibovics. I'm a prosthodontist and a member of the California Dental Association. I'm also the director of a dental residency, hospital residency program at Cedars-Sinai Medical Center in Los Angeles. We've had a clinic in that facility, a dental clinic, for over 50 years and a hospital residency program since 1989. We provided comprehensive care, especially for medically compromised patients with special dental needs, transplant patients, cancer patients, developmentally disabled patients, et cetera. We were doing approximately 8,000 to 10,000 patient visits in Denti-Cal per year. In June of 2013, our clinic closed, mostly because our census was reduced with the cancellation of the adult Denti-Cal program. We were able to restore the inpatient part of that program, but the outpatient program in the dental clinic is still not open, and the major thing that's standing in the way is the current rate structure. And the hospital cannot see this as a viable program under the current rate structure that exists. There are a multitude of fixes that are necessary for the Denti-Cal program to be a viable program in this state, but rates is certainly a major part of it. There's a great desire among dentists and other providers to care for these patients. Our program and our dentists want to provide for these patients, but in order to do so, the state really has to up its commitment to Denti-Cal patients. Add to this the millions of new enrollees in the Denti-Cal program that are coming through the Medicaid expansion and healthy families adding patients onto these roles. The problem only gets much worse. Please take action in this year's budget so that we can see some fixes in this area.
Thank you very much. Appreciate it. Next witness, please.